Okay, I'm delighted to be back again with Dr. JoAnn Manson. This is our third meeting, and we're going to be picking up on those years past residency and fellowship, where she is now stepping out into the beginnings of her professional career and her commitments to science. And I thank you once again for joining us for this Alma Morani Renaissance Woman Oral History Project. It's really important to be recording these trailblazers in the fields of women's health and in the lives of women professionals. So
thank you, Arlene. It's great to talk with you again.
Thank you. Yeah. So last time we left off, you were explaining to me, where your commitments to preventative medicine and research in preventative measures was taking hold of you, even in those early stages of your career, working as a fellow in endocrinology, witnessing late stage development in diabetes and cardiovascular disease, cancer, and the things that might be done to modulate or prevent the worst kinds of outcomes of those endocrine diseases. And so we stopped just as I was going to be asking you about the big decision to actually start to gain the tools of research through a master's in public health and then a doctorate in public health. And this is really kind of exciting. I know lots of researchers who don't do that kind of formal training, but you're combining your early years in clinical practice with obtaining this formal education and research. What prompted that decision? What made it an easy or a hard decision? How did you come to decide that that was the right path for you?
Yes, I was seeing a lot of patients with chronic diseases and late stages of chronic diseases, and I just became increasingly interested in prevention of chronic disease and doing actual research on that topic. It's interesting that in medical school, you tend to learn very little about research methodology, epidemiology, biostatistics, how to actually do this research. And so I thought that if I was going to actually be actively involved in this kind of research, I wanted to have additional tools and skill sets in order to be able to get grant funding and actually have leadership roles on grants. And I thought it would be very difficult to do that without getting additional training. And many of my colleagues were literally shocked that I was going back to school because it had already been so many years of school, college, medical school, training in internal medicine and endocrinology. And I also had originally planned that I would be a clinician almost entirely, that I would hang out a shingle or get some clinically oriented position and would not necessarily be going on to research. But I did feel that this was an area that was understudied and that more could be done. And I found it exciting, to think about being in research discovery, actually having the tools and the skills, to be able to do the research. So it became clear to me that I'd have to go back to, the classroom for that. I started with a Master of Public Health program, which, many physicians do actually feel that they have enough training adding the master's. It's a great program. I went to the Harvard School of Public Health and really enjoyed the MPH program. But when I got to the end of it, I felt that I still wanted to have more experience with research and learn even more about research methods. And so I applied to the Harvard School of Public Health, Doctor of Public Health program. And so overall, it was an additional 4 years to get the MPH plus the Doctor of Public Health, which is somewhat fast, I guess,
Yeah.
compared to what it is sometimes. But it certainly seemed like a long time, given that I'd already been in school for such an extended period. But I did feel by the end of the MPH and the DRPH that I was in a position where I really could begin to be actively involved in research, and that it wouldn't be too long before I could be an independent investigator, putting in my own grants and getting funding to lead grants. And so that's what was motivating me. And also, as I previously mentioned, I was really motivated to pursue women's health because I thought this is such an understudied field. There are so many knowledge gaps, and combining prevention research and together with women's health research would be very meaningful to me. Though I wasn't thinking I would focus entirely on women's health, but that it would be a key focus, a key goal to work on some of the really pressing clinical and public health issues related to women's health.
Okay, so couple questions for you. Just the focus on women's health. I know I've read that you were involved in some of the nurses' health study landmark sort of women's health observational studies. Did that happen during your training in health research, or was that later? When did you take up that a role in that important research?
Yes, I was actually very fortunate to become involved with a research team working in the nurses' health study and the epidemiologic research there. So while I was doing my doctorate in public health, I began to collaborate with other investigators in the nurses' health study, and my dissertation projects related to research in the nurses' health study. I started out being most interested in prevention of type 2 diabetes, the relationship between diabetes and as well as obesity, high body mass index, in terms of chronic disease outcomes, particularly cardiovascular, coronary heart disease, stroke. I was interested in those relationships and how to prevent type 2 diabetes and cardiovascular disease. This became a really major interest of mine. I was fortunate to be able to do some of the earliest work on physical activity as a means to prevent type 2 diabetes. It was surprising there hadn't been more research on that topic. A lot was known about the relationship between high body mass index and weight gain and risk of type 2 diabetes, but it really was not well understood how physical activity, regular, moderate, or vigorous physical activity or dietary factors and dietary patterns could affect the risk of type 2 diabetes. So I became very much interested in those topics. I was also very much influenced by one of my mentors, who was Walter Willett at the Harvard School of Public Health. Collaborated with Walter on several projects in the nurses' health study, particularly related to type 2 diabetes and cardiovascular disease. So those were my really early interests. But I became increasingly interested in randomized clinical trials related to prevention, because it seemed that many of the associations that we were seeing in
Right.
observational studies could actually be tested conclusively and rigorously in randomized clinical trials. And I was tremendously interested in that subject because the division that was my home at the time, I was doing my training in public health and doing, the doctorate in public health, was the Division of Preventive Medicine at Brigham and Women's Hospital, which I later did become the chief, the division chief of.
Right.
And there was randomized clinical trial research going on in that division. So I had an opportunity to experience firsthand some of the, needs of, for recruitment, retention. I was able to actually play a role in some of the research studies, the clinical trials, really understand what randomized trials involve in terms of the execution, the conduct of these trials and the challenges, the needs, the methodologic issues involved. And one of the trials that was going on was an aspirin trial,
Okay.
the U.S. Physicians Health Study randomized trial of aspirin. And we were talking also about trying to launch a new aspirin trial in women that would be limited to women, that would really help answer questions in both men and women about the role of aspirin in prevention of cardiovascular disease. And I became increasingly interested in doing these large-scale randomized placebo-controlled trials,
Right.
where it's very rigorous. That's often considered the gold standard of research, and it can actually convince clinicians to make changes in clinical practice. So I was involved in these two aspirin trials, as well as doing some research in the Nurses' Health Study on these questions.
Okay.
So I was doing research, in the Nurses' Health Study, looking at the relationship between aspirin and cardiovascular disease in women. I was looking at some dietary factors, particularly dietary supplements, taking supplements of vitamin E, vitamin C, vitamin D, beta carotene, and I became really interested in doing randomized clinical trials of these nutritional supplements where you can actually have a control group, a placebo control group. And one of the first randomized trials that I led was a study population of high-risk women who already had some risk factors for cardiovascular disease, or they had a history of cardiovascular disease. And I was interested in testing whether giving supplements of vitamin E, vitamin C, beta carotene, and later we added folic acid, B6, B12, the B vitamins, compared to placebo, would lower risk of subsequent cardiovascular events. And
People at risk, for women at risk.
For women who already had some risk factors for cardiovascular disease. And we were testing, it's possible to actually test each of these supplements separately, not just in a combined pill, when at the end you can't tell, is it
what was the active
is effective. You can't tell, is it the vitamin E, the vitamin C, beta carotene. we were actually doing the type of trial that is called the 2x2x2x2 factorial design. So each of these interventions was individually randomized to versus compared to placebo. It's a long story, but I became really interested in doing that kind of randomized trial research. And then when the Women's Health Initiative came along as an opportunity, and
let me
this
just get the dates here for some of this. I know you're in your MPH, PH, I can never get the acronym right, but your Doctor of Public
DRPH,
Health.
yeah.
Yeah. You're in that 1984 to 1987. So you're getting your chops as a health researcher in these different modes, particularly randomized controlled trials. When does the Women's Health Initiative, which was a large randomized controlled trial, if I understand correctly?
So I'm already doing research in the Nurses' Health Study by the mid-1980s, late 1980s into the 1990s. And I'm starting to do some randomized clinical trials, working on the aspirin trial, also in the late 1980s. And, planning with my colleagues in the Division of Preventive Medicine, this new randomized trial of aspirin in women. And around that time, I'm also planning this new randomized trial in high-risk women of vitamin E, vitamin C, and the antioxidant dietary supplements. Then, right in 1992, there was what's called a request for proposals from the National Institutes of Health for this new large-scale randomized trial of menopausal hormone therapy, the WHI, and I applied to be the one of the principal investigators of a clinical site. They just, we weren't notified until 1993, but the application process began in 1992. And our site in Boston at Brigham and Women's Hospital was selected as one of the initial sites, the Vanguard, 16 Vanguard sites. And so I became involved in the WHI. In 1993, 1994, we were doing recruitment. 1995, the recruitment actually lasted several years. And it was really interesting to me to become involved in the WHI for so many reasons. One was that it was addressing some of the most pressing questions in women's health, which was ultimately a major goal of mine, focus of mine, to be contributing in the area of women's health. And also because I was increasingly interested in randomized clinical trials, this was an opportunity to be involved in this large national, ultimately there were 40 clinical sites around the country.
Wow.
This large national randomized trial of women's health that was testing not only menopausal hormone therapy compared to placebo, but was also testing calcium, vitamin D supplementation, and
I didn't know that.
a low-fat dietary pattern that was increased fruits and vegetables and grains and lower intake of fat, to see if these interventions could lower risk of some of the most pressing, and most common chronic diseases for women: cardiovascular disease, cancer, osteoporosis, hip fracture, outcomes, some of these major health outcomes. So I was really interested in doing that, but it was a very major time commitment. I never regretted it, but my life was so busy at that
Yeah.
time because I was doing clinical practice in medicine and endocrinology, in internal medicine and endocrinology. So I already had a fairly busy clinical practice. I was doing research with some of these other studies that I mentioned.
Yes.
And at that time, I had two young children. I now have three children, but at that time, I had, when I started the WHI, my daughter was 6, my son was 4.
Oh my.
Um, they were very young, and yeah, it was a lot of fun taking care of them and spending time with them. But my life just seemed so totally hectic at the time.
I
It
can
really
imagine
was
every
a
minute on
a
days like
juggling
that.
act.
Yeah.
Fortunately, it was a fortunately or unfortunately, we were about to have try to have a third child, but because of some health issues I developed, I was advised to wait a while before a third
Okay.
child. So we ended up waiting quite a while. Both of us wanted, my husband and I came from large families, and we were thinking
Right.
of having 3 kids. So we waited quite a while. And actually, the third child, my son Joshua, wasn't born until 2003. So
Oh,
there's like
okay.
a 14, 16 year age difference between
And
his sister
very different stages of your
and his
career.
brother. They're
Yeah.
much older. He actually for a long time couldn't really figure out who they were.
Yeah,
He
exactly.
couldn't, he thought they were like, initially he thought they must be like friends of the family or something. He couldn't imagine that he had a sister and a brother that much
Uh-huh.
older. Yeah.
Yeah.
Um, but anyway, it was a very busy time, but I have to admit it was extremely rewarding. It was very exciting working on these randomized trials, and especially working on the Women's Health Initiative. And one thing I didn't mention was that when I was working with the Nurses' Health Study, I
Mm-hmm.
was doing some research on hormone therapy, menopausal hormone therapy. I was looking at the relationship between estrogen therapy and development of type 2 diabetes. I was
Oh,
collaborating on some projects looking at hormone therapy and cardiovascular disease outcomes, and kind of have the distinction of being the only WHI lead investigator, principal investigator who was also working on hormone therapy in this large scale observational study that ended up, the two types of studies gave very different results. Initially, the results seemed highly discrepant
okay.
between the Nurses' Health Study showing, that hormone therapy was associated with much lower risks of heart disease than women not that the women who were taking hormone therapy had lower rates of heart disease than women not taking hormone therapy. And in the WHI randomized trial, that was not found. There was no reduction initially. There did not seem to be any benefit, and there was even some concern about risk.
Yes, there was was there some point when they stopped administering the menopause estrogen as a kind of part of the study for fear of heart disease at some point in the
Well,
women's
the trial was stopped early. There were two separate hormone therapy trials, one
Okay.
in estrogen plus progestin in women who had an intact uterus, because the progestin is added to protect the uterus from endometrial cancer, And then there was a separate trial in women with hysterectomy, and
Okay.
that trial was testing estrogen alone. The trial of estrogen plus progestin was stopped 3 years early
Oh,
before it
okay.
was intended to stop, because it appeared that the risks outweighed the benefits. The goal was to look at chronic disease outcomes and the benefits and risks when used for the express purpose of preventing chronic diseases.
Uh-huh.
And the second trial, the estrogen alone trial, was stopped 1 year early. And the results were initially quite discrepant. However, over time, we were able to delve very deeply into the results of the WHI hormone therapy trials by a woman's age and time since menopause. And we were able to have a much better reconciliation of the findings from the Nurses' Health Study and from the large randomized trial of hormone therapy in the WHI, because it appeared that when you look at the women who were younger, who were in their 50s, they actually had a more favorable benefit risk ratio on hormone therapy than the women who were being randomized to hormone therapy in their 70s or even your late 60s or
So it
70.
depends on the woman who gets the therapy. It's not a one size fits all answer.
Exactly. It
I
seemed like
see.
a case of precision prevention. There were some women who were doing better, and the Nurses' Health Study population was largely women starting hormone therapy in their 50s or well below the average age of the women in the Women's Health Initiative. So after further study, there did seem to be more concordance or convergence of the findings. And that was actually really exciting. It was particularly seen in the estrogen alone trial, where the younger women seemed to be doing quite well on hormone therapy.
Mhm.
And also it became much clearer to readers and to clinicians that hormone therapy was still very appropriate for treatment of bothersome or moderate to severe hot flashes,
Right.
night sweats, especially in early menopause, that this was more a question of whether it should be started and used, for an extended period for the express purpose of preventing heart disease, stroke, dementia, cognitive decline. And I think many of these questions were answered and well addressed by the WHI, but some of the initial findings may have been very confusing to
Mm-hmm.
clinicians and to women at large. But over time, the messages have become much clearer, and the pendulum, it's really been a swinging pendulum with hormone
Mm-hmm.
therapy in the early years, like the 1980s, 1990s, before the WHI results were available. Hormone therapy was perceived as appropriate for all women, good for all women, very favorable. It had that
And not
perception.
just for menopause, but possibly for other prevention of other diseases.
Right. I mean, among menopausal women, but not just for menopausal symptoms. Exactly.
Right.
And for prevention of many chronic diseases. That was the perception prior to the WHI. And then when the WHI results were reported, and this was 2000, this was in 2002, the pendulum swung to the very opposite extreme of hormone therapy is not appropriate for anyone. It shouldn't be used. And many women were tossing their pills and patches, and many
Right.
clinicians stopping. And now the pendulum has come to rest in a more appropriate place, which is that hormone therapy is appropriate for some, but not all women. and it still
Mhm.
has a clinical role in management of moderate to severe hot flashes, night sweats, especially in early menopause. And decisions need to be more individualized. It's not
Uh-huh.
one size fits all. And women themselves really need to share in the decision making about whether or not they're treated with hormone therapy, whether they receive non-hormonal treatments, um, or whether they need any treatment at all, because some women will have milder symptoms. So it's been a saga.
Yes.
Over time, over the many, many years, the messages have become much clearer, the more nuanced. We've really been able to delve deeply into differences in results by age, woman's age, time since menopause, her underlying health status, other risk factors that she may have. And there's a clearer understanding of who's an appropriate candidate for hormone therapy and who isn't.
Is that a challenge to epidemiological research at large, that everybody would like a population health size answer, but the reality is, and I'm sure as you're doing this research, that it has to be delved down into the details before it can be useful advice. But does population health drive for the big answers and then have to pull back and find the moderate answers for different populations? So is this a
Yeah, I
constant
think I think there
hustle?
is tension. I think there continues to be a bit of a debate about if an intervention is not found to be of significant, statistically significant benefit in the overall study population, should you believe if it is of benefit in certain subgroups of the population? And there continues to be a lot of debate and tension on that very point. I think that we are increasingly understanding that many decisions do need to be personalized, and that interventions may be of greater benefit in some groups than others. We're seeing this for vitamin D, our trials of vitamin D supplementation, our trials of omega-3 fatty acid supplementation, that some people benefit. Some of this, like with the omega-3s, it may depend on whether you start out already having adequate nutrient status, and the people who are already at a certain level. I mean, it seems almost straightforward and obvious that if there's like a threshold effect and you don't really get additional benefit from taking more and more of something, and that's usually the case. You
Right.
don't usually, and we often say in epidemiology and in this field that more is not necessarily better, and it
Mhm.
can be worse.
Mhm.
Mega dosing is really usually like an optimal range of intake, especially for nutrients and certainly for hormones. I mean, this is something that's really clear in endocrinology. There are negative feedback loops to turn off production once you get to certain levels. Um, and so more is not necessarily better. And if a person is already getting adequate intake of various nutrients, or already has adequate hormone levels, they may not benefit from an intervention that is geared to increase their levels. But we are seeing that that some people benefit more than others. But it's complicated because sometimes you can see subgroups benefiting by chance, and you
Oh.
can't really be sure if it's real unless you replicate the results in a separate trial. So sometimes a really intriguing finding, like a hypothesis generated from one study or one randomized trial, then needs to be tested in
For
a
that
separate
specific,
trial with that specific hypothesis.
right.
Maybe the hypothesis that people who start out with a certain blood level or intake, nutrient intake, will benefit, and those who don't have those levels will not, whatever. If
Yeah.
that can then be tested in a second trial and replicated, then usually it will be believable by virtually everyone.
I see. So this, yeah, this changes, I think, my common and many people's common understanding that population health means us all. And in fact, population health means a lot of subgroups and a lot of variation in our population by
There is
gender, of
variation,
course.
but really, I mean, you raise a very good point that there are certain lifestyle factors and behavioral factors that will benefit the population very widely. And this is one of the reasons I'm so interested in the topic, that if you look at some of the lifestyle factors, behavioral being physically active, having a heart healthy diet, maintaining a healthy weight, avoiding excessive alcohol intake, getting adequate sleep, managing stress, being socially engaged. These are of benefit virtually to the entire population. And there are so many research studies now showing that the major chronic diseases in the United States and even worldwide, cardiovascular disease, cancer, type 2 diabetes, even all-cause mortality, are really impacted by very substantially reduced by having these healthy lifestyle factors. In many cases, such as type 2 diabetes, it's 80 to 90% reduction.
Right.
In other cases,
If these
it's more.
things are,
It's
if these sorts of risk factors are kept to a healthy parameters.
right.
Okay.
So there are many factors that really population-wide, there would be benefit. There are other factors that are more nuanced, sort of precision medicine, precision prevention comes
Okay.
into play. Some people benefit, others don't. It can become very complex, but I still do think there are some very general recommendations for population health and
Okay.
for, reducing risks of chronic disease, various
That
chronic
hold
diseases
across the board almost
that
without
apply
exception.
widely,
Yeah.
very, very widely to the
Yeah.
population.
Can I return you to a couple things that, the story of your arc through this research is raising
Yes.
for me? One of them is you mentioned, you had young children at a time of ferocious kind of engagement in major studies and becoming a PI on these studies. And, in a practical sense, how did you, and I know you're still doing clinical work in the clinic as well. What did
Well,
your
I've
day
gone
look
to,
like?
I'm really now focusing on the research and administration and mentoring. But
Right.
yeah, for
But back
many,
then, yeah.
yeah.
What did a day look like? How did you organize your calendar? How did you yourself get enough sleep, avoid stress, eat properly? Because I think for many people in the population, it's when life becomes too busy, too many demands, that we all let go of some aspect of what we might optimally want to do for our health. So it seems it's a population health question in another way to ask someone like you, well, how do you do all that when life is making demands from many directions?
Well,
How did you
I,
do it?
I mean, I won't deny that my schedule is crazy. It
Yeah.
was extremely hectic, and my days were very long, and I probably was not getting enough sleep. I would often experiment with just how little sleep can I get away with.
Right?
Um, and I was probably doing a lot of things that weren't really optimal for my health. But let me say that it was a challenge to juggle all these different things, but I was fortunate to have a good partner. I think makes a huge difference. You know, my husband was very devoted to the family
Right.
and helped a lot. You know, we like shared the child rearing and worked really well together in that way. And I think it's even more difficult, you know, when you don't have a really good partner in it. Also, childcare is so important. I mean, um, getting some help, having a person you really trust. You know, we had some experiences that you might say were not so favorable, but others that really were. And then we were very lucky to have someone we very much trusted to help out and taking care of
Right.
the kids. So, you know, there are a lot of things that you kind of have to seek out, and some of it is chance. You
Yes.
know,
Or
you're lucky.
resources. Yeah.
Yeah, some of these forces are a little beyond our control, but I'm not necessarily recommending to everyone that they try to juggle all these things at the same time. I mean, I had people really, you know, wondering why in the world was I trying to juggle so many different things. And you know, I think people make their own choices about this, and it was just really important to me for some of the reasons, you know, we've talked about. I really wanted to do research. I really wanted to and I loved my clinical practice, and I loved, you know, work taking care of patients and, you know, interacting with patients. I didn't want to give that up for quite a while. And, you know, it was really important to me to help, to be part of the answer in terms
Right.
of, it's one of the slogans we use in the Women's Health Initiative, be part of the
Uh-huh.
answer. You know, it was really important to me to be part of the answer in getting questions about women's health, you know, a lot because of my mother's situation and what we talked about. So I was very committed. It became almost like a mission to me to
Okay.
do these many different things. And also I wasn't quite ready to make a decision not to have a family, you know, not to have kids.
Right.
So I just kind of grit my teeth and said, okay, this is going to be really tough period. I'm going to be working really hard. My days are going to be really long, and I'm not going to get a lot of sleep, but I'm going to, you know, it will eventually get better. Though I have to admit, it hasn't gotten that much better.
Ah,
I mean,
yeah.
it has really been a hectic schedule for
All the
decades.
way through.
I
Yeah.
mean, people kept telling me, and I kept telling myself, oh, it's going to get better. You know, there won't be as many demands on you and blah, blah. You know, it kind of stays that way, but I really do think, you know, it may sound cliche, but if you find the work gratifying,
Hmm.
then you really are able to enjoy it despite the very hectic pace and the long hours. And I didn't really find it arduous and onerous. I just found it like, wow, this is really busy. I haven't even eaten lunch, you know, all of
Yeah.
these days, you know,
Yeah.
I'm not getting enough
Intense.
sleep. But
And
I
but
could keep going. I could still, you know, keep going and eventually get things, you know, more under control in my schedule.
right. No, it's interesting to think about the role that passion plays in giving us adrenaline and ability to keep going. And not feel burdened and
Yeah,
deflated. And I can see when you say you want to be part of the answers, but the excitement that comes when the answers start coming is a kind of a fuel of its own, I would imagine.
exactly.
Yeah.
Exactly. It seemed exciting enough that it was worth making sacrifices for.
Yes.
And I never really felt like I was being totally forced into it. I think when it's really, really tough is when you feel like you have absolutely no control over
Right.
your schedule. You have no control over any of the decision making that's going on. I
Yes.
felt that there were options that I could give up X, Y, or Z if I really had to, but I try to stay the course to do clinical and research and family.
Yes.
um, but at some point I realized it really was too much to continue doing all of those things.
And clinical is sort of what dropped out of the picture as
Yeah.
you
So,
switched.
in more recent years, I'm focusing on doing the research, the research, the administrative role as a division chief, and mentoring, which, mentorship, education, this is an area where I now feel very motivated, kind of
And I
passing,
know we're
passing
going
the
to,
torch
yes,
to the
we're going
next
to talk more
generation.
about that tomorrow in tomorrow's interview as we kind of get to that
Yeah.
more advanced stages of your career as you step into all those leadership and mentorship roles. I'm realizing we're coming up to 2 o'clock. If you had time, I would ask you just a one or two short questions to finish us off. But if you need to go, I understand.
No, I can take a few more questions.
Okay, just so we can be this early part of your career. One of the things that struck me as you're talking about this, dive into the research world. Now, I don't know for sure, but it sure seems to me like your progress was fast and furious. Did you feel that yourself? Like, boy, I'm getting my MPH and a doctor of public health, and here I am. I'm PI on studies. I'm being sought out for the Women's Health Initiative. It does feel like it all came very quickly. Maybe you were feeling like I was positioning myself for this. So was it a career that you plotted out and you were not surprised that you hit these things? Or was it a career that was like, I can't believe another door is opening. I can't believe I have another opportunity. Was it more serendipitous or was it more?
Yeah. I would say it was more serendipity than really fully planned out.
Okay.
I wouldn't really have known, for example, that the opportunity to lead clinical trials necessarily would have presented itself. It was fortuitous that I was working in a division that was doing these very large scale randomized trials, that I had done a few randomized trials during my endocrine fellowship and found that really interesting. So I was kind of, maybe was choosing to go to a division that was doing clinical trials to get more training, but to find a division like that was, I considered, fortuitous.
Okay.
And then the timing of the WHI opportunity in the early 1990s, when I was so much interested in the question of estrogen therapy and health, the benefits and risks of menopausal hormone therapy. I had begun to do some research in that area in the Nurses' Health Study, and that's an observational
Yeah.
study, not a randomized trial. And we often say with observational research that correlation doesn't prove causation. And the observational studies are so important, though, in so many ways. I mean, some associations are so strong, such as cigarette smoking and lung cancer, and even smoking and heart disease, and of course, you'd never do a randomized trial of cigarette smoking, but you don't even need the randomized trials of smoking cessation because it's so
Right,
obvious that.
right.
So observational studies have given a lot of really important answers, especially in public health. And also they generate the hypotheses that are tested in
Tested.
randomized clinical
Mhm.
thrials. So it's really important that to have both, as well as the basic science, the bench
Yes,
research. These are all really critical elements of the research foundation. So it was just really interesting to me as an endocrinologist, where of course this was hormones. It's exactly
yes,
but I was trained really interested in the health effects of hormones in the field of endocrinology. Then I started doing some work on this topic in observational studies. And then an opportunity came along for the first really large scale randomized trial of hormone therapy in women. And the opportunity to become involved in that with the focus looking
mhm,
at prevention of chronic disease. Does it prevent chronic disease? What's the benefit risk ratio in prevention of chronic diseases? That was of great interest to me, and it was kind of serendipity that it happened quite that way. But I've stayed very actively involved in that field for decades,
right.
observational as well as the randomized trial, and also looking at a lot of biomarkers, looking
Mhm.
at different biochemical predictors, does hormone therapy change, for example, biological aging, um,
Right,
really interested in effects on lipids and inflammation and, a wide range of biomarkers as well. So I would say a lot of it is serendipity. And I think that is the way it often happens for people in research. But I did have like a general plan or hope that I would be able to do public health kind of population kind of
mhm,
research that would answer some of the more pressing
yes.
questions, and especially fill knowledge gaps in women's health, because I do think the WHI in a randomized trial setting was addressing some of the key knowledge gaps in women's health.
Yeah. Yeah, no, I do hear people say, we often think, and I work with undergraduates, they all think they have to map their careers out, but everyone I talk to seems to acknowledge that I set a direction. I knew what I hoped to do, but it was a lot of things coming together in certain ways that allowed me to move forward. So the
And
other
you have to
question
be
I wanted,
open. You have to be open to
yes,
that, because if you map it out too specifically and precisely, you're going to let opportunities go by. I mean, definitely would have let some of those opportunities go by if I had already planned, okay, I have to submit this grant by
right.
October of this year.
Yeah,
So I don't have time to get involved in that new project that's just
right.
been announced. Yeah. So I think you need to be open to these
To what is
opportunities.
coming to you as well. You're right.
Yeah.
Yeah, no, that makes great sense. And I'm curious too, because our last couple talks, we've talked about what's it like to be a 4-to-1 ratio of a woman in medical school, and what is it like to be, in your clinical settings as a minority in terms of gender. So I'm curious about what the science world was like for women at the time, working in an area of women's health research, which I've heard from other people was sometimes not the mainstream, and there's a little bit of pushback against women gender specific research. And so what was that like for you in moving into this science world and establishing this identity as a woman? And I think women in science may have been even less plentiful at that point than women in medicine in clinical positions. So I'm curious, I don't know that for a fact, so I'll let you answer, but I'm just curious about being a minority, I'm sure, in this world of science?
Yes, I mean, in science as well, I always felt like I was in a minority, that there were more men in the room than women. I found myself in many rooms where I was the only woman or one of only two, maybe three women, and there were, 15, 20 people
Yeah.
in the room. So that was common. However, over time, I was seeing progress in this area.
Uh-huh.
I mean, it was definitely the numbers were balancing out quite a bit. And in some of the environments I was in, such as the Nurses Health Study Research Group, our Division of Preventive Medicine at the Brigham, and the Women's Health Initiative, these different
Yes.
research
Yes.
settings, there were at least as many women as men.
Okay.
And,
Okay.
even in terms of like principal investigators of the WHI nationwide, there were
Uh-huh.
many, many women. So it
But
was
that was a
starting
conscious
to
effort, was it?
balance out. And I had a lot of camaraderie with other women in science. And it was not really like the earliest years where it was 4-to-1 ratio in college and med school. As I said, it was about 4-to-1. Medical schools and Harvard Radcliffe became almost equal, really equal numbers. In fact, medical schools for a while periodically will have more women than men graduating. So it has really equaled out for training in medicine. There's still a ratio, unfortunate, fewer women than men who are full professors, who are chairs of departments or
Yes.
chiefs of division. In various leadership roles, there's still a gap, and a lot more progress needs to be made in those areas, but the numbers are definitely equaling out in terms of going into medicine and some of these other fields. Even some of the specialties are equal numbers or even more women than men.
And in
So
research,
I
would you
think
say the same? In health research, would you say I was a minority, now it's evening out, leadership is still in the hands of men? How would you describe the science world or the research world?
so. So I would say that in the research world, the numbers are in epidemiology, in clinical research, in public health research, the numbers are very similar. There are, it's very reasonable. The ratios are very reasonable. There is still a problem at leadership levels. And
Okay.
it is still a low ratio of women to men in top leadership positions. If you're talking about, chairs of departments, of academic departments,
Right.
even like research labs are more commonly men, and division chiefs and these leadership roles. Yeah.
Okay. So similar
Well, it's
picture.
improved. It's definitely
Okay.
improved, but it's not parity. It's not
Okay.
really equal.
And as you came through that ladder through your career, which feels more like an escalator because it seemed like it was going up very quickly, did mentorship matter to you? And who were some of the people? What are some of the stories of people who helped you gain the skills you need, gain the opportunities you need, the introductions you need? How did that work? Were they mostly men, I'm assuming? And did that matter? Would you have wanted a woman mentor, or do you think, who were your mentors? Tell me a little bit about the stories of your mentorship through your early career.
Yeah, well, I had a number of mentors within the, Brigham and Women's Hospital and Harvard Medical School, Harvard School of Public Health. but I also sought out a lot of mentorship in professional societies.
Okay.
So I became I became really interested in finding mentors at other institutions.
Uh-huh.
And for example, at some of the meetings I was attending, some of these meetings are the American Heart Association, the
Mhm.
Menopause Society, which used to be called the North American Menopause Society. I would interact with a
Right.
lot of women, researchers and leaders, clinical leaders in the field. And I would often, seek out their guidance. I mean, there are really too many people to name.
You'll
One,
feel like you're leaving
I
someone
would just
out.
say internal and external to my institution. Um,
Right.
I had many mentors. However, I became a division chief at age 46.
Okay.
So I was a full professor and a division chief at age 46. So I probably would have sought out even more mentorship if it had been later than that, because
It was an escalator. It was moving fast. Yes, I thought it was.
well, I mean, it didn't honestly seem that fast.
Uh-huh. Uh-huh.
I mean, it was still like taking many, many years of really, really long days and hectic
Yeah.
schedule. But I guess, that compared to my current age, certainly seems like a young age. But, at that point, my identity became much more that of wanting to mentor others, to be a mentor and a resource for other, for trainees and for faculty, rather than specifically seeking out mentorship for myself.
I
So
think that's almost a wonderful stopping point, because tomorrow when we meet, that's the sort of aspect of your career that I'd like to explore. In my transcript, I think we call it the mature stage of your career, whatever you want to call it, but where you move into administrative roles and leadership roles and mentorship roles, and those early stages of putting it all together and becoming the professional are sort of not done with, but in the rearview mirror a little bit more.